We're now kicking off round 3 of the day, which is focused on orchestrating the delivery of healthcare. So we've seen so many exciting AI tools being developed for healthcare, and I think it's equally important that these tools can be successfully integrated into existing clinical workflows and healthcare systems in a way that's actually going to be scalable and promotes rather than hinders adoption, and in a way that doesn't cause unintended harm to patients. And so I'm very excited to introduce our first speaker for this session. He's a physician who's an expert in integrating AI tools into real-time clinical workflows. Together, he and his team at the Duke Institute for Health Innovation have successfully integrated dozens of data-driven technologies into clinical operations. And he's also a highly sought-after advisor and thought leader in this area. So please join me in welcoming to the stage Dr. Mark Sendak.
So I just wanted to preface folks that I was asked to talk about an idea that I don't think anyone in this room would have heard of or may not agree with up front. So this will be a little controversial, I expect. So I'm going to talk about what are the real competitive advantages to being able to integrate AI and ML into clinical care. So we are all here because we roughly agree on this thesis. There's a massive opportunity to improve healthcare through the use of these technology tools. And there are dominant narratives for how this is done. And I'm going to spend the next 10 to 12 minutes breaking these down and telling you this is not the actual competitive advantage to being able to do this. So for example, it's not going to happen in Silicon Valley. It's going to happen in geographies with disparities, high levels of chronic disease, and consolidated markets. It's not going to happen in technology firms. It's going to happen in professional services firms. And it's not going to be tech and methods that drive change. It's going to be how organizations restructure. So this is the real competitive advantage, and I'm going to talk about how we're leveraging this at Duke and how we're trying to scale impact. So let's first talk about geography. I think we all know that this is a type of American exceptionalism that creates a lot of opportunity for us in this room. We have a particularly inefficient healthcare system, but it's not evenly distributed. So look at life expectancy across the country, see a lot of lower life expectancy in the South and Appalachian area. Look at poverty. You see a 10-year life expectancy difference among women and 15-year life expectancy difference among men, going from the 1st percentile to 100th percentile. Poverty is not equally distributed in the United States. Chronic disease is not equally distributed in the United States. And I know that we don't want to think of healthcare as political, but the reality is that if COVID showed us anything, it was the erosion of kind of the communication and how do we drive behavior change, and we need to be creative about how we reach people. And in a different vein, part of AI and ML is having access to data, having access to populations. When you think about reinforcement learning, you need to actually be able to iterate on things. And to do that effectively, you want consolidated markets. So this is about how prominent the biggest insurer is in the state, and then similarly, how prominent the big provider systems are in the state. So these are differentiators to think about when you're trying to do this work, because you have to be working on big healthcare problems that affect the masses. You have to be figuring out how to speak to different types of people who come with different perspectives, and you want to be able to access large populations with large data sets that you can work with. So next is, why is it not going to be in technology firms? I would say that it's going to be in professional services firms. This is a famous quote from the 1960s, I think. So we shape our tools, and therefore they shape us. The reality in healthcare is that our tools have shaped us for far too long. So many of us probably know this famous painting of what being a clinician used to mean, being at the bedside with patients. This is one of my favorite pieces about the use of technology in healthcare. Dr. Verghese is here at Stanford, obviously now. But it's the idea of the eye patient, that now you have these bunkers in which physicians primarily work, where they manage the digital representation of patients rather than being bedside. I was able to find an AMC's website that was marketing all of their physician workrooms. So this is a beautiful example of a physician workroom today. When I was graduating med school at Duke, we had to read about burnout. And I loved that the #1 strategy to lower your practice stress and get home sooner was to become an EHR champion. So clearly, our tools have shaped us. How do we strike back and shape our tools? So one of the things that you need is you need these different capabilities internally: data expertise, quantitative expertise, and clinical expertise. Unfortunately, in most organizations, these are siloed, and I would argue that in most technology organizations, there's not deep expertise in these 3 domains. What we've had to do at Duke is create the interfaces for these different groups of experts to interact, and in many cases, we've developed training programs and professional development programs to get people cutting across these silos. You also have to align the different levels of the organization. So I think this is honestly one of the most important aspects of being successful. So every year, we run a structured request for applications process where a C-suite decides on 4 to 5 strategic priorities. The team I work for, we report directly into the CEO of the health system. We put out the RFA, and then frontline workers get to submit their proposals to solve problems that they face in their daily routines every day. Then it's a competitive process to go through oral presentations, written reviews. When projects are funded, we have 12 months to scope out the solutions, develop solutions, implement, and evaluate. And we have to be able to communicate across these different levels of the organizations and iterate rapidly. And you have to have access to all of these different stakeholders. When you're building these systems, there is an extreme level of co-design and co-development. This is a publication from one of our collaborators, Kate Kellogg, an organization studies scholar at MIT Sloan, about how iterative this is and how you need alignment from these different stakeholder groups. Another quote from one of our collaborators, Madeline Ellish, who now is at Google Cloud: the idea that rather than deploying technologies to integrate them, you have to be asking, what are you integrating into? What is the relevant context? And I know that I think the word deploy is in the material for sessions today, but we have to be thinking about how things are situated in the context. I think Jeanne used the word socio-technical. This is something that we also learned about from our social science collaborators, to foreground the interconnected professional and social environments that we're putting tools into. And once again, if you're part of the organization and able to change the organization, you're able to do that so much more effectively. So the last competitive advantage is being able to change your organization and how nimbly the organization is willing to evolve and change its structure and professional roles. So this is from Kevin Shulman, who is also at Stanford. He was one of my first academic mentors. And he jokes, what other business do you walk through the front door and have the org chart in stone that hasn't changed in 100 years? So I'm going to give you some examples of how we've changed the structure. So this is one for chronic kidney disease. And it's a great example because this was one of the first data science ML projects that we did in 2014-15. And it leveraged a new entity that Duke had created called the Population Health Management Office. So they were one of the early participants in Medicare shared savings programs. This was value-based care. We have a population of 50,000 folks, mostly above the age of 65. We ran an existing algorithm to look at risk of progression of CKD. This is actually the project where we also built more sophisticated trajectory models for. And we found about 400 patients who needed to be reviewed after we screened out everyone who'd already seen a nephrologist, had initiated dialysis. So 400 people out there in the community who are in need of specialty services. and we don't know when their next scheduled visit is. There's not a workflow that exists today to intervene on those patients. So we created a workflow. We figured out, well, who needs to be in the room when we make decisions about what are the gaps in care and how to fill those gaps. We were able to get resources from the different departments aligned to test this workflow, which we called population rounding. So we aggregated data from claims, from the EHR. This is part of the benefit about having consolidated markets because you have a lot of historical data. You have inpatient, outpatient outcomes. We had this interdisciplinary team review the cases and then make recommendations that are sent to primary care providers and often scheduling these patients to get back plugged into care. So the other example is what we're doing with our sepsis watch system. So there had been a best practice advisory alert that was implemented within our EHR that was firing pop-up alerts. And we've published that 86% of the pop-ups were canceled, they were closed, there was no clinical impact, and it drove people crazy. So we had a frontline worker partner with an emergency medicine physician to apply to work with us in 2016 to not only build a new sepsis detection system, but to design a new workflow that wasn't causing a burden on the frontline workers within the emergency department. So we restructured the rapid response team. We actually had to pull the RRT team out of cardiology. So RRT teams historically were part of cardiology departments because they were mostly responding to acute MIs, heart attacks in the hospital. So we had to move them within the organization, put them into somebody else's budget, and start to broaden their purview. They now use sepsis algorithms, just general decompensation, ICU algorithms, but it required a lot of restructuring and training folks to do a different type of role. This is one of my favorite quotes from a qualitative study about how we're changing the way that nurses work. This is a study we just published with Kate Kellogg, the organization studies scholar. One of the things that we learned over the years is that even if you're implementing one technology for one clinical decision in a care path, you often need to align upstream and downstream users. So for example, when you're making a prediction about an event, the people who feel the pain from the event are typically downstream from the folks who are best positioned to intervene, who are upstream. So I'll give you a concrete example. There's a whole swath of patients who present to the hospital with pulmonary embolisms, clots in their lungs that are low risk who can be discharged home. So you have these ICU docs saying, hey, these patients don't need to be coming to the ICU. We need to be intervening in the ED and discharging these patients home. So they come and they say, hey, the ED needs to do something differently. And now you have this downstream user saying, hey, the upstream user needs to intervene and needs to fix the problem. That way I don't feel it. Well, guess what? People don't like being told to do something differently. So how do you build in the incentive to allow the upstream user to do that more easily? And someone else brought up, just make doing the right thing easy. So what the downstream users did is they said, okay, we're gonna block off clinic visits. When these patients are detected, we're gonna send the alert to a care coordinator who's gonna schedule the patient into an outpatient visit. That way the ED doesn't have to do anything and they can just discharge the patients home knowing that they're gonna have the appropriate follow-up. The other thing is to find your beachhead. When you're working within professional services organizations, you often feel like nothing can change and that really can get you down. But you're gonna find people who are willing to be your early testers, work with them, go after them, and they will become your evangelists and they'll work with you repeatedly. So we've had these repeat innovators. We've also continued to build workforce, and every year we probably help work and support 50 to 100 folks in the organization. And every project plants a seed, people see what's possible, and it kind of sets things up for broader change. So the last concept I'm gonna talk about is how do you scale impact? I've been with this team for the last 8 years, and I would say for the first 7 of those years, we were focused on building a really, really, really sweet island where we have ways of doing things at Duke that are really hard for anyone else to replicate, and the way we operate is really special, and it's kept me in Durham where I never thought that I would stay. But the reality is you can't scale islands. So this was a concept from a Stanford Entrepreneurial Thought Leaders podcast that I listened to a few years ago. But the idea is islands show people what's possible. They create demand for change, but they are not a supply for change. And if you want to meet the demand for change, you have to build bridges. So we're actually kind of embarking on a new journey where we're starting to build bridges. And a lot of that is through external partnerships. And this is where the Gordon Betty Moore Foundation has been a phenomenal partner, because you're trying to build capabilities outside of your own setting to kind of bring all organizations to a future state. So I'll leave folks with a question of, are you building an island, a bridge, or is it possible to do both? Thank you. Thank
you so much for that great talk. All right, so audience, again, just a quick reminder, for those of you just joining the second half of the program, if you have questions, please drop them in Slido and tag at Dr. Sendak. Same with the other speakers. So our next speaker is both a hospitalist and the Associate Chief Medical Information Officer for Inpatient Care and Data Science at the University of California, San Francisco. When she's not spending her time caring for patients, she's working on evaluating AI models for trustworthiness prior to implementation, and also deploying tools to improve patient safety and quality. So please join me in welcoming Dr. Sara Murray.
Great. Hi, everyone. Thank you for having me. I'm Sara Murray. I'm Associate Chief Medical Information Officer for UCSF Health, and I am an Associate Professor of Clinical Medicine. And I am going to speak with you about our pursuit of trustworthy AI for equitable care delivery. So what does it mean for AI to be trustworthy? As many of you know, the European Union put together a commission several years ago to think through this, and they outlined three key requirements that AI is lawful, ethical, and robust, and then they detailed 7 key requirements that applies to all AI, not just healthcare. We're still trying to get this right in healthcare, though, and so I'm going to walk you through an example and then hopefully give you a framework for thinking about it moving forward. So a clinic no-show is when a patient is scheduled for a clinic appointment and fails to show for whatever reason. It's a ubiquitous problem in healthcare. At UCSF, our patients no-show 2 to 16% of the time. We lose over 250,000 appointment slots annually. And there's profound revenue impacts as well as access impacts for other patients. And so Epic, the company, knows this. And several years ago, they built a model to address this for health systems across the US. Their model had 22 variables, and it output the predictive likelihood that a patient would make an appointment, with the idea that you could act on this, either to do something facilitative, maybe outreach for the patient to increase the chance that they make it, or if you're quite certain they won't come, then something like overbooking the appointment for another patient. So many clinics across the US just overbook at random because of this problem. So they know I have time to see 12 patients in a half day, so I'm going to book 15 patients in that half day. And that creates obvious frustration for patients and providers. It's hard to see 15 people when you have time for 12. So there's a lot of interest nationally in algorithms that can help do targeted overbooking the patients who are unlikely to make it to the appointment. But let's think about what that means for a second, right? So say you have a scheduled appointment and you're flagged by an algorithm as likely to no-show. You show up, another patient shows up, now you're probably waiting longer. You're potentially seen by a rushed, overworked provider. You may have a shorter appointment time, and so you can argue that you have a lower quality of appointment. I think we've all had this happen with the airlines, but there's a risk of this happening in clinic as well. So we started by looking at Epic's algorithm for no-show, and it was immediately clear that many of the features in their algorithm were these protected demographic features. And if we were to overbook based on these features, it could obviously result in worsening of existing inequities. So we started by saying, we're just going to build the model without these features. We're going to build the model based on the patient's prior no-show history, and then features of the appointment itself, like time of day, day of week. And when we did that, we actually built a model that performed nearly identical to Epic's. And we shared this with Epic, and actually in their version 2, which is what's widely available now, they also exclude all these demographic features. But it brings us to the question, like, are we good now? So is a model that predicts future no-shows based on prior no-shows fair? And I would argue that it's not, based on bias in the underlying data and in society in general. And I think there's an example in the criminal justice literature that actually illustrates this beautifully. So you may have read this a few years ago in ProPublica. So COMPAS is a widely available proprietary algorithm. It predicts criminal recidivism, has 130 survey questions, never asks race. But it asks questions like, how many of your friends were ever arrested? And we know in a justice system that's biased with systemic racism, questions like this will induce bias into the model. And so ProPublica looked at this, and they found that black defendants were much likely to be labeled high risk, but not go on to reoffend, while white patients were more likely to be labeled low risk, but actually go on to, so I keep calling them patients, I'm just used to saying patients, these are defendants, but actually go on to reoffend. And so, essentially, remember this model was never asking about race, but it was automating discrimination based on race because of the confounding and bias in the model and the questions. So likewise, the problem with building a model for a future no-show based on prior no-shows is that oppressive structures, systemic inequity could be driving the original no-shows. And so patients may be missing their appointment because they have transportation barriers, limited work flexibilities, they can't afford parking, they can't get out of work, they don't have sick leave, they don't have childcare, or maybe they distrust the US healthcare system based on the history of racism in the US healthcare system. So we recognized we couldn't get all of the bias out of this model, but what we could control is what we do with the model. And so we decided that we would only use this model for patient-positive interventions, things that benefited patients, like reminders and outreach. And we spent a lot of time educating our leaders at UCSF that the model couldn't be used for overbooking. And when we piloted this, we had a modest improvement in no-shows across the organization. The challenge is that educational, and this is true across informatics and healthcare, educational interventions are very difficult to sustain in the long term. And then once a model's in production, particularly if it's a model that's just telling you the likelihood of an outcome, it's really difficult to control how it's used. And so 2 years later, we looked and we saw that actually this model was being used for targeted overbooking in a select few clinics at UCSF. So the key to evaluating models for fairness are understanding how they're going to be used. So let's look at how this model is being used. So what these clinics had basically done is they set thresholds. So the highest risk patients were recommended for overbooking, and then the medium risk patients were recommended for additional outreach. And what we found was it was actually recommending additional outreach fairly equitably, proportional to the amount of patients who were actually no-showing in that race ethnicity group when stratified. But it was disproportionately recommending overbooking for Black and African American patients, especially compared with Asian American patients. So my group is working to socialize this idea around UCSF that we have to select the operating point of the model wisely. This starts with choosing the desired intervention. So you have to know whether you're building a model because you want to do something facilitative, like reminder calls in this case, or if there's something potentially punitive, like overbooking. You have to know the number of interventions that are operationally feasible, right? If I have the bandwidth to make 100 calls, I can seek a different sensitivity than if I only have the bandwidth to make 10. And then once you know your desired intervention, for facilitative interventions, you're targeting your high equitable sensitivity, but for punitive or potentially patient negative interventions, you're really targeting high equitable positive predictive value. So what did this look like in this model? So remember, the sensitivity is a proportion of patients who the model flags as likely no-shows among all the patients who actually no-show, where the positive predictive value is the number of patients who actually no-show among all of those who were flagged as likely to no-show. And as you know, balancing positive predictive value and sensitivity can be challenging. And in this case, you have to pick what you care most about. Because if you're seeking equitable positive predictive value across all your race ethnicity groups here, you're going to get different sensitivities, and the vice versa is true as well. So this is really challenging. It's also challenging because the positive predictive values don't tell the full story. So you may see differences because there's actual difference in model performance across the groups, and that can be due to bias or confounding in the underlying data. You could also have existing interventions that are being applied disproportionately. So say one race ethnicity group is less likely to have accurate phone numbers recorded in EPIC, they may be less likely to get the calls. And then even if you think you're applying interventions equitably, they may actually be less effective in certain groups. So say I'm sending reminder calls in English, that may not be as effective in a largely Spanish-speaking population. And then taking a step back even further, there are times when it's appropriate to disproportionately apply interventions. So the COVID pandemic was a great illustration of that. We did targeted outreach for vaccination in the communities that were already suffering disproportionate burden of disease. So choosing the operating point of the model is really challenging. It requires a lot of thoughtful attention, but you can only really think through it if you know what your planned interventions are going to be. So if the key to evaluating a model for fairness is understanding how it will be used, the model also needs to dictate to the user how to use it. And so either your model can be predicting the intended action, or it can be predicting something else, and through the user interface or workflows that you've established, you're effectively displaying the intended action. So models that predict outcomes in healthcare are a dime a dozen, right? Sepsis, length of stay, readmission, deterioration. Everyone's got many models for those things. Likewise, likelihood of no-show. To build better models, we have to start changing the questions. So likelihood of no-show is not particularly useful. What would be useful is to actually understand who's going to benefit from a conversion to a video visit. Who would benefit from an additional reminder call? Who's limited by parking or transportation challenges where we could do outreach there? And this doesn't just apply to the question of no-show, right? Deterioration is another issue that we have at UCSF. We have a very overworked rapid response team. But predicting deterioration with suboptimal positive predictive value is probably not that useful for us. We need to actually know what interventions would be useful. So who needs IV fluids in our hospital that's not actually receiving them right now? Who needs more aggressive respiratory therapy support? Where should we be doing infectious workups where they're not yet underway? So take-home points. Our developers should be partnering with our operational leaders in healthcare to design models that drive specific interventions. Models should be evaluated for trustworthiness based on those desired interventions. And then those desired interventions really need to be clear to our end users. So my goal is for, I think this is a very broad audience, for us to work together, developers and leaders in healthcare, move past just predicting the interesting outcomes towards predicting meaningful interventions. And I think that's the way we'll ultimately move towards more trustworthy AI. So that's it.
Thank you, Dr. Murray. Actually, if I could ask you to stay on the stage, we're going to do our panel Q&A session now with Drs. Sendak and Murray. And again, a quick reminder to those of you joining us online, we'll sit on this side this time, to please feel free to drop your questions in Slido. In-person attendees, feel free to line up at the mics. So I guess I'll start off with a question for Dr. Murray.
Yeah.
So In order to develop models that don't or are not biased against particular, for example, racial or ethnic groups, what's the best solution? Do you think that such models should actually be trained and only deployed in a population with, let's say a particular racial or ethnic group? Or are there other ways to develop models that generalize well across all groups?
So that's a great big question. I think that the goal that a model performs perfectly equitably across all racial ethnic groups is actually really difficult to achieve. Potentially impossible in some cases, in many cases. And so I think the more important thing is that we're actually cognizant and thoughtful about the bias that exists in all of these models. And there are like technical ways you can optimize things, but from the implementation standpoint, we have to be cognizant of the bias, evaluate for the bias, and then think about how we're using the model, most importantly, because there's huge potential always to propagate the bias. So.
Absolutely. Dr. Sendak, any thoughts on that?
We have multiple, so I can give a few concrete examples where we've seen disparate model performance. So one of them actually came from the Bay Area. It was a Kaiser Permanente NorCal model for predicting incident HIV. And so they did this on a very large cohort. It was like 3 million people. And being in Northern California with the disease dynamics of HIV, the model did not identify a single female who went on to develop HIV. And so we asked the question, well, okay, in the Southeast, with different disease dynamics, let's try to build our own algorithm. And we were better than nothing for performance in a female, the subgroup, but it still was not on par with males. So I think when you're caught, first off, you need to know, but then also understanding that it will require further work, and we don't have a solution for that yet. We've also seen algorithms that if you're trying to predict mortality, it'll perform way better on people who die from cancer than people who die from something else. So there's often specific things that kind of are substantial signal that crowd out other areas. So if you're trying to elevate other patient characteristics to make sure that those needs are met, I do think you have to have a targeted effort to do that. And whether that could be vulnerability across any number of characteristics.
Absolutely.
And I mean, it comes back to the fact that the data you're working with is often not like the data you actually want, right? So if you want to predict no-show equitably, you want the answer to, if everything else was equal in life and everyone had equal opportunities and resources, who would still no-show the clinic appointment? But I don't have that data, right? And so then you have to realize what you're working with and the fact that it's challenging to build something equitable based on that.
The one other thing that I think speaks to this area, especially in outpatient care, this is something we'll be publishing in the coming months, there's this idea of impactable patients, and that patients can be more impactable with chronic disease interventions if they have less social barriers to care. So if you're trying to, as an organization, obviously you're making trade-offs of, okay, I have a person who has time for X number of patients to review. So you have to at least be mindful of how you're allocating people's time to make sure that you're not just going for the easiest patients to serve.
Right, I think that's certainly a danger, right, when publishing results on these models. We always choose the easiest patients to serve. Makes the machine look better. I've got one more question in the Slido chat. So this is for Dr. Murray. Can you suggest ways that UCSF can make it easy to do the right thing, per Dr. Sendak, with the no-show model that you talked about?
Yeah, so I mean, we're working on that right now. So what we've done after we came back and saw that it was being used in a few clinics for targeted overbooking is we engaged in a collaborative with our Division of General Internal Medicine to revamp how the model is used. And we actually rebuilt it again. And what we're doing is exactly what I mentioned, building a tool that basically tells people what to do. So these are the patients who need an additional reminder call, because we know if a patient gets a reminder call or text and actually confirms it, they're like extremely likely to make the appointment. So who could we get those additional reminder calls to? Then if people don't confirm their appointment, who actually, like, historically based on the data would probably benefit from a video visit, like they could make that instead of coming into the city in person in UCSF, which can be challenging. And so that's how we're addressing it, is changing what we're not just, it's relatively meaningless to just say this is the likelihood a patient's gonna no-show. And it's unfair that we put that in front of our front desk staff and ask them to make a decision how to act on that. And so what we need to be doing is putting in front of them the right thing to do for that patient. And that's how we're framing it now.
Great.
One thing about actionable models, so every year we work on like 10 to 12 different projects, and many of them are models. And I think for a long time it does really help to make models actionable. I will say there's been, mostly during COVID, there's been 2 cases where we've built models that are more situational awareness, and it's capacity planning. So one is like, trying to help with EMS routing of patients within our hospital network and know what the load is within each of the EDs for how to route. And then the other is once patients are in the ED, predicting the need. And this is just how many patients do we think are going to need inpatient beds or ICU beds. So my thinking has evolved during COVID, but I generally agree 100%.
No, and don't get me wrong, we do that too.
Yeah.
So we're partnered with industry right now on building a model that basically models throughput through the hospital for capacity management purposes. And the idea is that you just put information in front of the people whose jobs it is to act on that information. Problem is they're like always acting on suboptimal information. So it's getting them the information and then getting them some modeling around what we think is going to need to happen in the hospital. So I think there are cases where that's meaningful. I think when I think about actionable models being really important, it's like what we're putting in front of a single individual, like a front desk person to act on, or even a clinician. That's where it's really hard to just give people a likelihood of a bad outcome.
It looks like we have one burning question from our in-person attendee.
So Sharif, wearing my clinical informaticist hat. So obviously there's a lot of talk about social determinants of health, and I think there's a big push to bring in social determinants of health into the electronic medical record. And that always, obviously my intention is good, but I'm always worried about what is the potential backlash. And so I'm wondering if either of the institutions, are you bringing in social determinants of health from some outside source? What have you done to put in some safeguards around that so that we don't get situations where we're actually amplifying bias? And then the last thing, I'll actually put a plug, I think Leo's gonna talk next. Leo was posting, I don't know if he did it or someone else did it, some really interesting work where he kind of hid from the algorithm the biases, but they were able to find the biases. I don't know if he's gonna talk about it, but super cool stuff, so.
I can expose layers of the problem just to say there's not an easy solution. So one of the things that was very vivid during COVID was how much Duke and the Southeast generally was not situated to respond to the massive need in the Latinx community. So I'm from California. The Latinx community here is much more visible and prominent. In the Southeast, it's a lot more migrant farm worker community. And one of the things that really struck me, we had a really hard time kind of meeting people where they were for COVID, for vaccines, for outreach. I appreciated the difference between privacy and safety. I think that we mostly talk about privacy, but I don't know the extent to which we recognize that people don't feel safe. in interactions with healthcare systems. And this was in the summer of 2020, where there were stories of deportations happening in healthcare settings in the Northeast where people were showing up. So that was one setting where it was really clear that people were very mindful of what data was captured about them. And the other place that we've seen this is in transplant. And we are actively doing a project to try to improve equity in transplant allocation and transplant listing. And that's a scenario where if you just think of like a game theory approach and you're trying to optimize your own chances of being listed, you present a set of information that make you seem like a really good candidate. And the more that we try to supplement patient information with other types of records and data, once again, the incentives aren't fully aligned, and patients, it's going to be really hard for us to continue to build trust directly with patients and make sure that we do have a full picture about what their needs are.
Absolutely. Well, I think we're at the time limit for this panel, but again, definitely encourage everyone to continue the conversation online. And please join me in thanking our speakers again, Dr. Sendak and Dr. Murray.